So today I'm going to talk about migraines and hormones. So welcome to those that joined. I hope you're having a good Sunday. I've just come back from London, managed to make it in time. So I thought I'd talk today about migraines and hormones because they're so important but actually not spoken about and still not understood enough. Now I suffer with migraines, so I have a lot of personal experience but also professional experience. I've managed and treated a lot of women and men actually over the years with migraines, and I have quite a lot of academic interest in migraines. So the next half an hour I'm going to give you a brain dump about migraines. Thank you for all your questions. I have looked at every single one and I'm trying to incorporate the answers in what I'm going to tell you over the next half an hour or so. Now, migraines are really common. Now, they affect about 1 to 2% of people, and they're sixth highest cause of years lost to disability, and they're the third commonest disease. So you would think, wouldn't you, that there's a migraine specialist clinic in every hospital, that everybody's trained about migraines, that it's a real priority for research. And as many of you might know, that's not the case at all. And I wonder whether it's something to do with migraines being far more common in women than men. That's me being cynical, but I think it does have something to do with it. We know that men and women can get migraines, but women are more likely to develop migraines than men. And the peak age is between 35 and 45. Now, in my mind, anything that's more common in women, that's more common between the ages of 35 and 45, we've got to be thinking about hormones. I think it would be almost negligent to not think about hormones. So what are migraines? There's lots of people, when I say that I experience migraines, they just say, oh, is that a bad headache? It's not actually. Well, it is, but it isn't. It's far more than just a headache. We still don't actually know why migraines develop. We've always been taught, and I was certainly taught at medical school and as a postgraduate, that the arteries, the blood vessels in our brain dilate, they get bigger, and that causes the migraines. Now, we don't actually know whether that's a cause and effect, or whether everybody has dilatation of the arteries in the brain. And actually, lots of people have dilatation of the arteries and don't have migraines. So there must be other factors that are going on. Obviously, the pain receptors in our brain can be activated or more sensitive in some ways, and it's thought actually it's also due to the changes in the endothelium, the lining of blood vessels in the brain as well, but it will be multifactorial. Migraine does tend to be genetic, so it can run in families. So for example, my mother has migraine, my maternal grandmother had migraines, my eldest daughter Jessica has migraines, and sadly each generation they've got worse. So many of you might know, if you follow Jessica Anderson on Instagram or heard me talk about her or heard our podcast together that we did in October, she's actually registered disabled with her migraines, and it's been really difficult journey for all of us, but especially for her. Thankfully she is improving, but I, over the last 2 years where she's been really crippled with them, I've obviously learnt more and more, and she's had the most amazing treatments. Now, with migraines, often people get what's called an aura, so they know that there's something's changing in their body, and it can really vary. So everybody's experience of migraine is very unique and different, and many of us find that each migraine can affect us in very different ways as well. So what I'm talking about today is just very general, really. A lot of people find that they feel just a bit weird and a bit different. So before a headache comes on, they might feel a bit nauseated, feel a bit sick. They might feel that they're more sensitive to noise, or they're more sensitive to noise and sounds. They might be more sensitive to lights as well. Some people find that they yawn a lot more. I find that I get really hungry, although I shouldn't be hungry. I feel like I just sort of need to eat. My speech goes quite a lot, so a lot of people find they can slur their words, or they become clumsy. I find one of the first signs is that I'm just dropping things and I can't think sharply. My brain feels all fuzzy. Some people just find moving is really difficult and hard to concentrate or multitask as well. And then after that, not for everybody, everybody actually, not everyone gets the pain of a migraine, but a lot of people get very severe headache, and that really varies. It can be continual, it can be throbbing, it can be one side, it can be both sides. It's quite hard to say categorically what a migraine headache is like. Many of us have one side that's more affected than others, but it really varies. And when the headache comes, it can again really vary. Sometimes it can be a mild headache that you can sort of keep trying to work through and keep functioning. Other times I literally feel like I've been stabbed in the head and I just cannot function at all because the pain is so severe. So it really does vary. Sometimes migraines can last for a few hours. Some people find that they last for a lot longer, and again the intensity of the pain can really vary as well. So they can be really variable. When people have the intense pain of the migraine, again, they might have other symptoms as well. So they still might feel sick, or sickness might have come on. They might feel that they're very sensitive to light and noise. They might even be sensitive to touch, smells actually as well. People find that their sense of smells, their sense of taste can change. I find that everything tastes a bit metallic-y. And often when you're in the throes of a migraine attack, you might find your coordination goes. I know my daughter's fallen downstairs before. She's found it really difficult to even climb the stairs just because her coordination really goes. And so you can see with some people, it's almost they've been misdiagnosed as having a stroke or something else going on with their brain. My daughter used to be told off at school because they thought she'd been drinking alcohol because she acted like someone who was really drunk or even under the influence of drugs, and she was neither. It was all related to her migraines. So that can go on for several hours, and then after that, when the headache goes, often people have this, it's called a prodromal phase, where people feel quite washed out, really tired, quite vacant. Can also affect your mood, so people can feel quite low as well, quite tearful, just really that sense of doom, and it can be really horrid. So it can last the whole from the aura with the migraine and the prodrome for some days can last a couple of days or so, sometimes longer. Some people are more fortunate and it's less. It really, really varies. Now, some people find that they don't get the actual headaches, but they get more dizziness, more poor coordination, more feeling nauseated. And we call often those vestibular migraines. And you can see that a lot of people end up, we see a lot of women who've gone to an ENT, an ear, nose and throat specialist, make sure there's nothing going on in their inner ear or even their brain. But actually, when you take a really clear history, it's often episodic and related to migraines. So this vestibular migraine might not be associated with pain, but it's this overwhelming sort of inner ear, poor balance, feeling quite dizzy, quite disorientated, clumsy as well, with poor coordination as well. So it can really vary how migraines can affect people. Some people, my husband's actually only had 2 migraines in his life. He's really lucky. And one of them actually was triggered because we had some light bulbs changed in the garage, and he went into the garage and just that harsh white light triggered a migraine. And actually this sounds awful, I was fairly pleased that he had it because he made me sympathise so much more for what I go through. Because I think unless you've experienced a migraine, you don't actually, it's really difficult to understand. Most people have had headaches, but these are completely different. They're very systemic. They're not just the head. The whole body can really be affected as well. So they can really vary in frequency. So like I say, some people only have 1 or 2 ever. Other people can have them a lot more frequently, and we call it episodic if people have had less than 15 migraine attacks in a month. If it's more than that, or if they have more than 15 headache days, so it might not be migraines every day, but headaches every day, and they have to have at least 8 migraines a month, so they're only pain-free for 15 days or less in a month, then we call that chronic migraine. And that can occur in a small percentage of people with migraines. And chronic migraine is up there. It's like the third most the most common cause of disability. It can really affect people, and you only need to dig a little bit into social media and you can see the effects chronic migraine can have on people. Really, really difficult. Now, there are all sorts of things that can trigger migraines. So the first thing when we do as doctors, when we see people, is taking a really clear history. And as I've said many times before, a lot of times, which is what I was taught as an undergraduate, as a medical student, it's all in the history. So we spend a lot of time really prying and asking lots of questions about the headaches, but not just the headaches, about all the associated symptoms that people might experience as well. So if you feel that your doctor or your healthcare professional is prying a lot, it's actually with good reason. So we can really get a real understanding for what's happening to make sure that we make the right diagnosis, of course, so we can think about treatments. So there are various triggers and everyone's different, so this is a generalisation, but many people find certain things can trigger migraines. So personally, the things that trigger my migraines are if I don't eat. So time restricted eating is quite difficult for me because if I know that if I didn't have breakfast and waited till lunch, it would trigger a migraine. I actually personally don't drink alcohol and I don't have any caffeine because that can trigger migraines. So that means for me, no caffeine, no tea, no chocolate, and absolutely no alcohol at all. Even alcohol in food can trigger migraines. The other thing that for me, this is me personally, but it can be very common for lots of people, that's why I'm telling you, is that certain foods can trigger migraines as well. I find that certainly if I was going to eat some sugary foods or some processed foods, so if I went to a shop and bought a meal deal, so a sort of processed sandwich and a packet of crisps, then I know that I would get a migraine later. And it's probably, as I've spoken before about nutrition, it's probably due to that sugar spike. So if my sugar levels are sort of nice and even, where I'm eating food that really fills me up and I don't get any spikes, then I'm far less likely to get a migraine. So not eating can trigger a migraine, or eating the wrong foods can cause or trigger migraines. And it's sometimes difficult to know when you're busy and your diet hasn't really changed. And the thing that made me realise is that when I stopped having processed foods, when I cut out caffeine and alcohol, I noticed that the frequency of my migraines really reduced. So it's sometimes worth looking at your diet. We often ask people to make a headache diary, and sometimes even a diet diary as well, which can be laborious, but it can be quite revealing actually if you write things down and try and work out what your triggers might be. I also find that if I don't sleep properly, so that means actually, which is a real pain, not having lies in at weekends, going to bed the same time, getting up the same time. So if I shift my bedtime by an hour or two because I want to stay up late on a Friday or Saturday night and have a lie-in on a Saturday or Sunday, I know it will trigger a migraine. So I'm the most boring person in the world. I go to bed the same time, I get up the same time, I eat my meals the same time, I try and eat the same sort of food, and I drink lots of water. So if I drank some juice or some squash, I know that would trigger a migraine as well. So it sort of forces me really to eat well, which isn't a bad thing, but it means that I have to be really prepared. So if I'm out all day, I have to take my food with me. I can't just nip out and buy something because I won't know what's in it. And that's just something I've worked out over the last 50 odd years of having migraines to really optimise, because actually the most important thing about migraines is not having them. I'll talk about treatments, but what we really want to do is just not have them at all, or reduce the frequency as much as possible. Of course we do. So foods can trigger not eating, not sleeping, changing your routine. Actually, exercise. Before I had my third daughter, I used to do a lot of cycling. I did quite a lot of long cycling, long distance cycling. So I was often out for 3 or 4 hours at a time. But I found that I had to be really obsessed with how I ate and what snacks I took. And I definitely got more migraines because I was exercising more. As many of you know, I do yoga now. And I think it's just an exercise that suits me. If I was doing a lot more sort of high intensity exercise, I think it would probably trigger migraines. So they do absolutely rule my life, but I don't have as many as I would do otherwise. So it's just like anything, it's weighing up what you want to do as an individual. So I'm not saying that everyone needs to have my lifestyle. I'm just saying that's what's worked for me. Now, I said right at the beginning, didn't I, that migraines are far more common in women than men, and they peak between the ages of 35 and 45. So that's got to ring some alarm bells in people, but also in healthcare professionals, because things that have an increased incidence between 30s and 40s in women, we've got to be thinking about hormones. Now, many people find, and actually quite a few questions that people have written in today, is saying that they often get migraines just before their periods or when they ovulate. Now, there's that graph where people's hormone levels, so estrogen and progesterone, they start off low on the first day of the cycle, and then they quite quickly rise up. And then when people ovulate, you get this big peak, and so you get a high amount of estrogen and progesterone. And then the second half of the cycle, those levels reduce. And just before our periods, the levels of estrogen and progesterone are very, very low. And I've said this before, talking about PMS and PMDD and symptoms that can occur, which are the same as menopausal symptoms just before you have a period. And then people often have a period and start to feel better. So if you can imagine, just before your periods, when the levels of estrogen and progesterone are low, that can trigger a migraine. But also you get this big peak and trough in ovulation, and that can trigger a migraine. Less commonly, but it still can. And then a lot of people say that when they go through puberty, that's the first time they've had migraines, and it's more common. We know the incidence is more common when people start having their periods compared to children. But then also when people are perimenopausal, there can be an increased incidence of migraines, or many of us notice that our migraines become more frequent, more severe as well. And often, like, I didn't really think about it when I was in my mid-40s. I had all these other symptoms, but as many of you might know, I didn't recognise it due to my perimenopause. And actually, because I was getting a lot more migraines in my 40s, that's when I started to experiment with my diet. I didn't even think about my hormones. But we know our brains like everything to be really calm. We use a term in medicine called homeostasis. And the homeo bit means the same, and stasis means stable. So it's like everything is really stable in our brains. So all those things that I spoke about before, like not eating, your sugar level will change. Eating processed foods, your sugar level will change. Not sleeping the same amount, then your brain has got to accommodate and change. So when we've got a change in hormone levels, that can trigger migraines as well. And we also know that estradiol and progesterone and testosterone are very anti-inflammatory on our blood vessels as well. And so this whole change about with migraines affecting our blood vessels, causing the blood vessels to dilate, is probably not helped by not having enough hormones as well. I'm not aware of good quality research looking at the role of our sex hormones on migraine, which is really, well, it's just frustrating, isn't it, that we haven't got this research. But it's just a very common working hypothesis that we know that hormones are going to be related to migraines, because we see it and listen to the stories all the time, and it doesn't surprise us. So in ovulation, you can get a peak and trough very quickly, which can trigger. And then in the perimenopause and menopause, our hormone levels are often doing this with a downward trend. And so people that don't take HRT will often say that they felt worse in the perimenopause, and then when they became menopausal, their migraine frequency reduced. But actually, I've already said many times before that replacing hormones, especially replacing hormones in a natural way, giving body identical HRT, actually has more benefits than risks for the majority of women, because we know it improves other menopausal symptoms and also improves our future health. So what we don't want to do is say to migraine sufferers, sorry, you can't have HRT, which has so many benefits. And this is where we need to dig a bit deeper when we're thinking about hormones. So stay with me, because it's important that people realise the difference between the synthetic hormones and the natural body identical hormones, which I have spoken about before. There's lots of information on the Balance website and the Balance app about this. But many people who have migraines are told quite rightly that they can't have the combined oral contraceptive pill. because the tablet of estrogen and the synthetic progesterone both increase risk of clot. Now, when people have a migraine, and people have, especially when they have aura with migraine, there's a very small increased risk of stroke. It's only very small, but in medicine we don't want to increase even a small risk by giving a medication. So we usually say to people, you can't have the combined oral contraception and you can't have tablet estrogen because of this small risk of clot. But the natural body identical hormones through the skin as a patch, gel or spray, there's no risk of clot. The micronized progesterone, the testosterone as a gel or a cream, there's no risk of clot. So it means that actually you can have the natural body identical hormones even if you have very severe migraines because they don't increase risk of clot, which is very reassuring. But I've also said that the change in hormone levels can trigger migraine. So what you want to do is try and have a good level of hormones where it's very balanced and it's flattened out. Now everyone's different, and so sometimes when people have PMS and they have migraines just before their periods, but they're still having regular periods, they have no other symptoms during the month, we might try giving them some estrogen and possibly some progesterone just for those few days when they're suffering from symptoms to top up what's missing. And that might be enough just to cause that imbalance of hormones. So throughout the rest of the month they're fine. When they have their drop, they just have those few hormones then. So that's in women with PMS or PMDD, especially if they have other symptoms as well. Now in the perimenopause, I've already said, our hormone levels are really chaotic. So often giving hormones back can take a little bit of a time to work out the right dose. Now personally for me as a doctor and a menopause specialist, I usually, unless there's a reason otherwise, I usually recommend for women to have patches rather than the gel. And the only reason I say that is because when people have patches, you can have a constant level of estrogen all the time because the patches are a slow release of the estrogen that's being given through the skin into the bloodstream, so it's pretty constant. Of course it will change a little bit because there's some metabolism of the drug which can vary in different ways, and don't forget our bodies still produce estrogen. I've said before, our brain produces estrogen, our bones, our muscles, even our heart produces a bit of estrogen, so there will be a little bit of fluctuation. But even the gel does get absorbed very slowly and regularly into the arteries and the veins. It actually, there is a little bit more of a peak. So the morning that I rub a gel in, for example, there'll be a bit of a peak, and by the evening it will plateau out. And if people like me are very sensitive to small changes, then having the patches might be better. Now in the perimenopause, sometimes, and again it varies, if women have too low a dose, you're still going to have hormonal fluctuation from your ovaries, and it can still trigger migraines. So sometimes what we do is increase the dose, and we increase it so that your own hormones aren't fluctuating, they're suppressed. In the same way that for people who don't have migraines, who take the contraceptive pill, that has higher doses of estrogen than we give in HRT because it suppresses the ovary working, obviously, because then it doesn't produce an egg and the person won't get pregnant. But we do that sometimes with people on HRT. We stop this hormonal variation by giving slightly higher doses of estrogen. Now, it's not the actual level of estrogen, I don't think, just in my huge clinical experience, it's not the level of estrogen that can trigger the migraine, it's the sort of speed to that level. So with ovulation, because it's a big up-down, that's what's triggering it, not the level that it gets to, if that makes any sense. And so sometimes with migraine, people who suffer with migraines, you have to go very slowly to increase the dose to almost trick the body that there's not any change. Because if I suddenly say somebody needed a 100 microgram estradiol patch and they used it straight away, then they might find that their migraines are triggered and worse because the body's suddenly having to go up to that level of estradiol. Whereas often what I'll do is say, have the 100 patch and then cut it in quarters. And then this is off license because the drug companies say we shouldn't do it, but it's a matrix patch. So if you cut it, you'll just get a quarter of the amount. And then you could just gradually sometimes I do it really slowly over 3 to 6 months if someone is really suffering from migraines. and then gradually increase the amount. So it might take 3 to 6 months for them to be on the 100 micrograms, which is the amount they need to suppress those hormones sort of varying. So that's the estrogen side. It's very individualized. We usually go quite slowly. Like I say, usually use the patches, and I'm saying usually because everyone's different. That's what's really important for all of you listening, that we have people have individualized consultations with someone who really understands how you are and what's going on with you, and also the options available for you. So that's the estrogen. Now we've got the progesterone, and I've already said when I've spoken about progesterone before, it's very anti-inflammatory, so it reduces inflammation on the brain, it works in our blood vessels as well, and it's probably beneficial for migraine as well. The synthetic progesterone has a small risk of clot and stroke, so it's not ideal for people who have migraines, but the natural progesterone probably is. Now, there's some people who take the progesterone cyclically for 2 out of 4 weeks if they're perimenopausal, and often people with migraine don't enjoy that because they say that their migraines can be triggered, and that's probably because they're taking something for 2 weeks, stopping for 2 weeks, starting, and so you're getting a fluctuation of hormones. So for many people, even if they're perimenopausal, I might recommend them to start with a continuous preparation. So they take one progesterone, either orally or it can be used off license vaginally if that's preferable, continually all the time. Now, if you're still getting periods because you're perimenopausal, you might find that that will trigger some irregular or erratic bleeding. But I tell you what, if you're a migraine sufferer and that helps your migraines, you'll put up with some bleeding, and usually the bleeding will settle with time. It might just take a bit longer. So that's an option for people. Now, the other hormone that I think will often works very well for people is testosterone. Now, we don't have any evidence about testosterone and migraine, and that's because the studies haven't been done. As I've said before, testosterone is normally all about a female libido, although we know it's a biologically active hormone that works all around our bodies, including in our brains, and our brains produce testosterone as well. So I've found, just in clinical experience, having prescribed testosterone now for many years, that people who have migraine find that the frequency and the frequency and the severity of migraines really does reduce when they use testosterone. It has to be using it over at least 3 to 6 months, so it takes a little while to have an effect. But many of us have noticed, myself included, that the frequency of migraines when using testosterone in a female physiological range can really make a difference. Now, obviously, hormones aren't the answer for everything. I would be absolutely mad to think that hormones would cure all migraines. Unfortunately, they don't. So when we give treatment for migraines, there are 2 real sort of groups of treatment. So we give treatment for the acute attacks when people have the acute migraine. And then the other thing we try and do is give prophylaxis. So this is to try and prevent migraines occurring. And the 2 things are quite different actually. So I'll just spend a few minutes talking about both, if that's okay. So if someone's having an acute attack, and it's really before their pain comes, if you can recognise these aura, so when you're yawning, you're just feeling more tired, maybe a bit spacey, someone looks at you and says, "Oh, are you okay?" My husband knows when I'm getting a migraine. I don't know why I have this really pale, vacant look. He says he can see it in my eyes. That's when you need to take something to abort an attack. You don't wait for the migraine to come on. But if you're anything like me and my daughter, your brain doesn't think properly, and you're not really thinking about how to treat yourself. It's a really weird concept, but I've done it many times. And so now my daughter and I have a rule that she phones me if she thinks that she might be thinking in a weird way, and I literally talk her through what she needs to take, because her mind is just all over the place and it can make a big difference. So some old-fashioned treatments can work really well. So aspirin, you have to be over 16, so not for children, but aspirin can be really good, but it has to be the dispersible, so it doesn't taste very nice, and it has to be a higher dose. So it's 300 milligram aspirin tablets dissolved in water. So that's 900 milligrams of aspirin dissolved in water. Now also with that, people often have anti-sickness as well. So there are different anti-sickness. Some of them are on prescription, some of them you can buy over the counter. But things like prochlorperazine can be useful. And domperidone is something else which improves the gastric emptying, which basically means that when you have the aspirin, it's more likely to get into the bloodstream as well. So an anti-sickness and the aspirin should, I mean, I have them in my handbag all the time, can be really, really useful. And also, even paracetamol can make an effect. It's a very mild painkiller, but some people find it helps. Now, the group of drugs that has made the biggest difference, certainly since I was a junior medical student, are the triptans. So the first one that came out was sumatriptan, and now there's lots of different triptans. The names, so there's naratriptan, there's zolmitriptan, they all end in triptan. That's the clue. And actually, what they do, they're selective serotonin agonists. And people have lower serotonin when they have a migraine. An agonist means it boosts the level, and they think it works on the blood vessels, but I think it probably has other effects as well. They can be used in different ways, so they can be taken as a tablet. But if you're feeling sick, and often what happens is the stomach doesn't empty very easily, that's why these drugs that help empty the stomach can be good. So if you have a tablet, it might just sit there in the stomach and not do anything. So you can have them under the tongue, or you can have them on the tongue to melt. There's a nasal spray. There is an injection, but actually having the ones, so I use zolmitriptan melts, so it basically just melts on the tongue, and it'd be great, especially if you're out and you haven't got a glass of water, or you've had the disposable aspirin and you don't want to have more fluid, you're feeling awful, you can just literally put it in. They come in different strengths. Some people find that they get side effects with the triptans. Now, the sumatriptan was the first one that came out. It's called Imigran is the other name in the UK, and a lot of people get side effects to it. It's quite long acting. People can feel quite spacey with them. Actually, they can cause nausea as well, and it's really difficult to know, is the side effect due to the medication, or is it how I'm feeling because of the migraine? And it's not until you've maybe tried another type of triptan you'll notice the difference. So it is worth, many of us have to go through 2 or 3 triptans, sometimes more, before you find one that works for you. But it is worth persevering, because they can abort an attack. So especially if you have disposable aspirin, an anti-sickness and a triptan all together, as soon as you feel that something's coming on, that can really make a difference. So that's really the sort of gold standard for an acute attack. But if you're getting frequent attacks of migraine, then it is worth speaking to a doctor or a specialist about prophylaxis. And there are lots of different treatments that are available. We've sort of, what's quite difficult is that there's new drugs coming out, but certainly in the NHS you have to have failed other drugs before you can get to them. And I find that very frustrating, because some of the drugs that are tried have more side effects, and actually when migraine's so common, we should be really fast tracking people to get the treatment that's right for them, because we know so many days sickness are lost to migraine, and it's just can be so awful when you know there might be a treatment that will be suitable for you, but you can't get it. And we know certainly in the NHS, but even privately as well, it's really difficult to find a migraine specialist, and it can take a long time to be referred to one as well. So we do have different drugs that can be used. Some of them are used for other things, so they're actually all used off licence, but we know that they're safe drugs for other reasons. So some people use what's called a beta blocker. The commonest beta blocker is propranolol, that works, it goes through the blood-brain barrier, and it can help the way the blood vessels work, but it can cause side effects. So some people feel quite tired. Some people can have really vivid dreams. They can feel quite flat in their mood. Some people are fine. So it's certainly a good first-line prophylactic to try if you're experiencing migraines. Some people there's a drug called candesartan, which is actually an ACE inhibitor used for blood pressure. Some people find that can be very useful to use. My daughter tried it, but she kept fainting actually because her blood pressure kept dropping even at a really low dose, so she couldn't use that. And she also tried the propranolol, but that did make her feel very flat and low in her mood, and very, very tired and lethargic. Then the other ones are some of the amitriptylines. So there's different groups in that family. They're actually used as antidepressants, but they can help to stop trigger migraines. So there's amitriptyline, there's nortriptyline. My daughter also tried something called dithiopin as well, which is another type of antidepressant, but it can work for some people with migraines, but she had awful side effects with that as well. There are other drugs such as topiramate, which is actually an epileptic drug, and there's something called pizotofen as well. They all can have side effects actually, and it's balancing whether they're beneficial and if the incidence of side effects outweighs the benefits for reducing migraines. Some people can try 2 or 3 different, so it can take quite a long time. The other thing that we have to be careful is if you're using all these drugs, you can get what's called overuse headaches. So if people are using too many triptans or having too many painkillers, you can get rebound headaches as well, and even worsening migraines. So that's why a headache diary is really, really crucial. Now, there are other treatments as well. Many of you might have heard of Botox, as in not for cosmetic reasons, for migraines. And so there's an actual Botox protocol that's given. So it's not just in the forehead, it's around the head and it's down the neck as well. And neurologists can give that as well. On the NHS, it can be far more difficult to get. And that can be really good for many people. There are some new drugs that have come out. They're called calcitonin gene-related peptides, so CGRP, and they're antibodies to this calcitonin gene-related peptide. So it was found that there was more of this peptide around with people with migraines. Now, these drugs are given as an injection, and they last different lengths of time according to what they are. There is one actually, I think, that's out as a tablet as well. They're harder to get hold of. The NHS say you have to fail certain drugs before you can be considered for them. But some people use them, find that they're transformational. They've made a huge difference. The commonest side effect with them seems to be constipation. Sometimes can affect mood as well, but they're worth considering as well. And then there are some newer antibodies that are coming out as well, some tablets and some injections. So there's lots of things advancing. There's also something called Kefali, which is a little sort of magnetic, or it's like a TENS device that goes on the forehead. It's only quite small, and that can be just bought online. Anyone can buy it, and they're a very good company as well. They're very supportive, and that can be really good for prophylaxis and treatment. There are different frequencies and different lengths of time that you use it for. So many people use it they use it regularly to reduce the incidence of migraines, and then when they have an attack you can change the frequency and it can really make a difference. So it's worth thinking about. And then there is a magnetic device. Actually, my daughter has one which gives cranial sort of magnetic sort of field through the brain, but it's a big heavy device that it's prescribed. It's prescription only because I don't know the long-term effects, but it can be very beneficial, and certainly it has been for her. So anyone who has migraine needs to think about their lifestyle. Like anything in medicine, it's really important that we look at our lifestyle and do as much as we can without medication, without layers of these medications that I've spoken about. Some people find that supplements can make a difference, and there is a bit of evidence actually. So a good quality magnesium supplement, a good quality fish oil can really make a difference. And there are some others. And if you go onto my podcast with Katie Monroe talking about migraines, and I'll put some links to some migraine resources on my story after this, then she talks about supplements. I'm a bit sort of erring on the side of caution, because some of the supplements, if you take them regularly, can be quite expensive. So anything that you try it for 3 months. If it makes a difference, then carry on with it. And I know personally, taking a good quality fish oil and magnesium has been really good for me, but it might not be good for someone else. So just try these things and see. So it's a lot of information. As per usual, I've gone over half an hour, and I've got over hopefully the most important tips for you, but really important. So just to summarise, that migraines can be vile. They're more than just a headache. So make sure you see someone who understands how bad they are and have this multi-pronged approach. But for many women, they've tried loads of things, but the hormones is the missing bit. So make sure, if you do think it's related to your hormones or your perimenopausal or menopausal, see a doctor who can really understand the role of hormones, estrogen, progesterone, testosterone, for migraine prophylaxis as well. So I hope that's been helpful. Next week I'm going to talk about heart disease and the menopause, because it's Heart Month in February. So we've got a lot of resources, but I will post on Sunday morning. Any other ideas for future topics, just put in the comments, because I'm going to post this on my grid now. So enjoy the rest of your evening. Thanks so much for your huge amounts of support and lovely messages that you keep sending. So thanks very much, and I hope that's been useful.